All right, our next speaker, the wellness doctor from Ontario, Canada. Dr. Steve Rallis is a licensed doctor of both chiropractic and naturopathic medicine, adjunct faculty at the Trinity Medical School in Integrative Medicine. Dr. Rallis received his undergraduate degree in biological sciences from Western University in London, Ontario, his chiropractic degree from Parker University in Dallas, Texas, and his naturopathic medical degree from the Canadian College of Naturopathic Medicine. Dr. Rallis has a keen interest in both research and education, and his private practice in Ontario is one of the world's first to offer integrative functional medicine rotations for medical students. He is also the Chief Medical Officer for the DRIP Bar in Canada and the United States. His published and ongoing research is focused on the integrative treatment of cancer and metabolic diseases. He is an author and international lecturer, having lectured to patients and physician groups through North America, South America, and Europe. And side note, his family also produces my favorite premium olive oil from Greece. So check it out, Rallis olive oil. So please welcome Dr. Steve Rallis to the stage.
Thank you, Valise. Can everybody hear me okay? What a privilege to be here. What a privilege to be here. I'm so excited, and thanks to Dr. Timms, wherever he went. I have all the time in the world to listen to you, man. It's so good. And because, too, like Dr. Timms, there's a lot of speaking heads and talking heads out there. But the one thing that's true is that we see patients every single day. So my particular topic and talk today is going to be a little bit more targeted and maybe not as granular as Dr. Timms. It's going to be a little bit broader. But any questions that anybody has anytime during the conference, feel free to sort of reach out. How do we switch? Is there a... Wrote a book last year specifically for my patients. When oranges become apples, what your oncologist won't tell you about IV vitamin C in cancer. So if you are on the fence or know of someone who needs to understand how IV vitamin therapies work, how somatic mutation theory works, you know, Dr. Timms talked about the somatic mutation therapy. We have, we're lucky enough to have integrative medical rotations for medical students. So I'm very familiar with the curriculum, having gone through 4 years of chiropractic, 4 years of naturopathic medicine, teaching medical students. I know exactly what the curriculum is. Having done an undergraduate degree in biology and biochemistry, the somatic mutation theory is responsible for about 5% of cancers. The original research scientists who posited that theory never even studied cancer. And yet, it's still the dominant, it's what we teach all of us, it's what we learned. So as long as we continue to pump our ideas into a theory that really is happening downstream. And what this basically means is that if you had a breast cancer and you could have the exact same type of breast cancer but have multiple different mutations for the exact same type of cancer. In other words, there's a heterogeneity to the cancers, not a homogeneity. And that's really, really important because, again, this sort of speaks to that sort of seed soil idea. But anyhow, let's dive in. This is from chapter, I think, 4 in my book. My office, it's not a cartoon, by the way, the book. I threw this into chat, and I said, make the first 4 sentences into a cartoon. So my office manager, Renee, put down the phone and turned to me. Jenny has canceled her treatments. Her oncologist told her not to have any IV vitamin C treatments during chemo. Did the oncologist give any reason, I asked. They didn't, she responded. She could see the disappointment spreading across my face. This was a patient with a very aggressive cancer. And what you're going to find out about IV vitamin C is it's oftentimes the most aggressive types of cancers that are most amenable to this therapy. like KRAS positive colorectal cancer, which we're seeing with increased frequency. We had 3 patients this last month in their 30s. We've had over 5 cancer patients over this last month in their late 20s, early 30s, with no family history. And it's oftentimes the most aggressive forms that are most amenable to this. So when I had done the workup, I'd read the reports. So when I knew she canceled her treatments, what was happening? What is the oncologist thinking? How is it with all of this research that's out there, patients are still being discouraged from pursuing integrative therapies? When we think of vitamin C, we think of it as an antioxidant. The orange, right? That's what they're thinking. They're thinking just in general terms, I'm administering a treatment that is oxidative. So why on earth would you skip down the street, have an IV infusion of an antioxidant? It's one thing they're thinking, I'm sure, but we know that IV vitamin C doesn't behave that way. And yet to this day, it's still unclear. And today, my single and sole purpose is to make this very simple argument, a very simple argument understood by you guys at least, and whoever else is watching out there. So let's dig into this and let's go back in time to the 1970s. Story starts here. Dr. Ewan McGregor, a Scottish surgeon, was treating end-stage cancer patients with IV vitamin C. This was in Scotland at his hospital setting, and was getting, and these patients were called at that time untreatable. So they had sort of exhausted and gone beyond the standard of care. And Linus Pauling at that time had found out about Dr. McGregor's work and found it very compelling. So he reached out to him, and they began a series of communications and correspondence. And Dr. Pauling was famous for vitamin C, had already started his vitamin C theory, had his ideas on the benefits of of nutrients, not IV nutrients. So he reached out to Dr. McGregor and said, I'd like to do a study with you. And they did. Published in 1976. They took 100 patients, compared them to 1,000 controls, and in the hospital they were given 10 grams of IV vitamin C. Now in our practice, we're typically administering more than that, right? But 10 grams IV vitamin C for 10 days and oral dosing thereafter. Here's what they found. Increased survival time. By the way, this was published, all of these journals are still available in full PDFs today, so you can download and read the whole thing. So in the Proceedings of National Academies of Science, and again, it was published in that journal because that journal at that time was almost the top of the food chain in terms of scientific research. And Linus Pauling fancied himself a scientist first, one of only 5 two-time Nobel Prize winners. So what they found was that they lived 3 times longer, 210 days versus 50 days. That's significant, especially because a lot of new drugs for end-stage cancer, you'll see, barely produce that. And in the context of everything that you're learning today, and learning in your journeys, because most of you probably know more than I do, but in the context of your journeys, what you're going to find out is this is one therapy. And where conventional medicine falls down, where our research models fall down, is this idea of we're always looking for one cause, one cure. And that is one of the inherent mistakes in everything that we're doing. Hey, did you hear about this? Or this new drug? Or this new therapy? Or if you smoke this, or if you do this, and that's going to cure cancer. It isn't one thing. It isn't one thing. I always tell my patients, what makes a successful Thanksgiving dinner? Pick one thing. That's a patently ridiculous, it's a rhetorical question. It's a patently ridiculous question, really. It isn't one thing. Some person will say, oh, it's turkey, it's stuffing, people. How about if you have turkey and stuffing but no people there? Or the environment, or maybe it's the cranberry, or maybe it's this, or maybe it's X, maybe it's Y, whatever it is, it's all of those things. Care has to be complete. You know, the truth is, conventional oncology doesn't need integrative therapies to be profitable. But the patients do. Because the standard of care represents about 1/10 of what a patient needs. You absolutely need this. I've done this with so many patients that I can tell you definitively, these numbers here, just for IV vitamin C, just at a dose that is actually probably subtherapeutic, make a difference. How about if you combine this with other metabolic therapies? How about if you add in mistletoe? How about if you change the nutrition? How about if you add off-label medications? How about if you add certain supplements? How about if you begin to change everything? What happens then? So this became a big deal. When this was published, this got a lot of popular press. Linus Pauling thinks cancer may be a disease of vitamin C deficiency. That's not true, but that's what he thought. But there was also blowback. There was also blowback after this study was published. And so much so that they said the controls weren't properly accounted for. There was a lot of issues with it. And of course, Linus Pauling, being a Nobel Prize winning scientist, thought, that's fine. We'll do the study again under tighter controls. And they did. This time they lived 300 days greater than that of the controls. So this began to move the needle, as you can imagine, and received a lot of popular press. Here's just, I think this is from Prevention magazine. Truck driver, for example, responded with remission of all signs and symptoms of cancer. Remission so dramatic and complete that his doctor began to doubt the accuracy of the original diagnosis, which actually happened to me. We had a patient that was told she was palliative. We started treating her. And 8 months later, when she went for her follow-up, they said, we must have misdiagnosed you. And she had called and said, look, I've been given less than 6 months to live. And I was referred to your clinic, and I'd like to come and see you. I said, okay, what's the circumstances of the condition? She told me. I said, look, and the one thing, and you know, Dr. Timms will say this as well, we promise to provide care to our patients. You don't make promises of cure, you promise to provide care. If you fully assess everything, you can begin to make targeted treatments. And she said, well, I'm gonna go to Europe. When I come back, I'll come to the clinic. She came, wonderful woman, we started treating her. And she went to the doctor and said, yeah, there's no evidence of disease, we must have misdiagnosed you. So enter Charles Myrtle. This guy was the OG, the original quackbuster. Hated everything related to natural medicine, believed it to be an affront to the orthodoxy of conventional medicine. And under the guise of the Mayo Clinic, undertook to redo, in good conscience, Dr. Pauling's and Dr. Cameron's work again, so that he could spread it to the masses. Published 1979, 1980, New England Journal, shamefully. Two groups showed no appreciable difference in changes in symptoms, performance status, appetite, or weight. The median survival of all patients was about 7 weeks, 50 days. Remember, it was 50 days in the 1976 study, it was 50 days in the 1978 study. They lived exactly 50 days, and the survival curves essentially overlap. In this selected group of patients, we were unable to show a therapeutic benefit of the high-dose vitamin C treatment. Published, Popular Press, New York Times, September 1979. This was the nail in the coffin. When the dominant voice of an industry is also the most divisive, it becomes an issue of politicking based on fear and fear-mongering. And it's this tradition that actually still persists. It still persists. Like there's this idea that this is good medicine and this is yet unproven medicine. It's not true. It's completely not true. Last week, a controlled study of 150 Mayo Clinic patients showed cancer, published in the New England Journal, showed no evidence that large doses of vitamin C help. That's the nail in the coffin for vitamin C. And a therapy that was so promising, and you mentioned it, Dr. Timms, just recently, that there is really no epigenetic influence that IV vitamin C doesn't help. Let's fast forward. Let's go forward in time. Early 2000s, pharmacokinetic studies started to be published. Now, pharmacokinetics in very simple terms means how a drug is metabolized, or the intake and the metabolism of the drug. In other words, the journey of the drug in your body is called pharmacokinetics. Everybody in this room is going to know this forever now. Vitamin C concentration in the blood is 80 to 100 micromolar. Everybody say that, 80 to 100 micromolar. So what is a micromolar? So the way I describe this is if you had a pitcher of lemonade, 1 liter pitcher of lemonade, and you added 80 granules of sugar to that pitcher of lemonade, that's 80 micromolar. So 80 little things in 1 liter of water. Okay, so that's 80 to 100, that's 80 micromolar if we're making lemonade. Concentration in our blood is 80 to 100 micromolar. Now we test vitamin C on most of our patients. It's actually not 80 to 100 micromolar, but that's the published data. The threshold for vitamin C to exert any type of a therapeutic effect, any therapeutic effect. So if we have a patient with colitis, as an example, or a skin condition, and we want vitamin C IV to exert a therapeutic effect, it must crest 300 micromolar. So far, so good? Okay, here's where it gets interesting. Vitamin C, no matter how much oral dosing you do, will never crest 220 micromolar. Because very interestingly, what we found out was we assume that most small molecular weight drugs follow what's called first order kinetics. That's what we teach our medical students. In other words, if you take a drug and you double the drug, it doubles the dose in your bloodstream. Almost all small molecular weight drugs do that. Nutrients like vitamin C do not. It's tightly regulated by the gut, the enterocytes of the gut, very tightly regulated. So no matter how much you consume, this could be 1 gram, 2 grams, 3 grams every hour, every 2 hours, every 3 hours, you will not crest 220 micromolar. And what do we say the therapeutic? 300. Just to have baseline therapeutic dose. In fact, for cancer, we need at least 10,000 micromolar. These are levels only achievable through IV vitamin C. So if you are under any type of illusion that you can take oral vitamin C and it has a benefit, it does not. In fact, the 1979-1980 study, famously done by the New England Journal, proved that. There is no cancer patient on planet Earth that won't benefit from IV vitamin C. Michelle and I ran about 30 of those IVs before we left for the conference. And it sometimes feels like the starfish story, you know, throwing the starfish. It's not even, we're not even making a dent. We're not making a dent. And sometimes I'm invited to speak at conferences, I don't go because I'm thinking, I can't go, I'm seeing patients. What happens if I'm not there? Something also very interesting happens to vitamin C through a very complex reaction, its interaction with iron and with copper. Vitamin C at high doses becomes hydrogen peroxide. That's very interesting. Also interesting is we have an enzyme in our blood, glucose 6-phosphatidehydrogenase, G6PD, that makes the hydrogen peroxide that's produced non-toxic to our cells and toxic to the tumor cells. So IV vitamin C becomes selectively cytotoxic. And again, this effect is magnified in ketosis. It's magnified with other nutrients. It's magnified with antimicrobials. In fact, the whole theory too, this is just one of my theories, that one of the reasons that patients begin to respond is because you begin to unwind some of the underlying issues that were triggering or causing or propagating or perpetuating the cancer to begin with. Because we know that if you mix it, if you combine IV vitamin C, like let's say with an antimicrobial like doxycycline or artesunate, which is an antimalarial, you get a magnified effect. We know if we have a patient with sepsis, you get a magnified effect. So the H2O2, the hydrogen peroxide, is pushed into the tissue cells. And again, if you use hyperbaric oxygen, the reason you would use hyperbaric oxygen is, again, you're driving the hydrogen peroxide from the bloodstream into the tissue more aggressively under pressure. Does that make sense? And again, the reason you would use nutrients like berberine or curcumin or metformin was to make that cancer cell starving for it. I guess it's funny when they'll say it doesn't matter if you eat before a cancer treatment cell like chemotherapy. Most cancers that are highly glycolytic, meaning that they're using glucose to drive into the tissue cells, if you're well fed, you're less starving for the nutrients or for the drugs. So all of these metabolic therapies begin to compound on each other. So we know that it depletes, and in terms of the back to our original story, the IV vitamin C, or the chemotherapy, one thing that IV vitamin C does very famously is it depletes the glutathione in the tumor cell. So glutathione is our main antioxidant, and it's stored in the tumor cell as a protective mechanism. And if you have IV vitamin C before chemo, the glutathione levels in the tumor are radically reduced, such that under chemo, it becomes more toxic. And I know for certain in the future we will be using chemotherapies, but at much less toxic doses. That's for sure. Like Taxol, which interestingly is still one of the main drugs that it's used, is a 1960s plant medicine from the Pacific U. But how it's used and at the concentrations it's used, it becomes so toxic. And this is where chemotherapy and standard oncology becomes a net zero gain. If you're doing a therapy that is destroying your immune system, specifically, Dr. Tim's talked about the blood test. When you're looking at neutrophil to lymphocyte ratio, and the neutrophils start to go up, and the lymphocytes start to go down, which always happens with chemotherapy. It is your lymphocytes, your natural killer cells, your T cells. That's where therapies, especially like mistletoe and high-dose vitamin C, are critical. They're maintaining the lymphocytes. They're maintaining your immune system. Without an immune system, you can't do the final kill, period, end of story. You can't. It's why it always comes back. It's why we never talk about cancer treatment in terms of cures. We talk about it in terms of 2 years, 3 year, 5 year projections. Because we know it's coming back, because the moment you suppress the immune system, and all chemotherapies are myelosuppressive, they're affecting the rapidly producing cells in our body. And what are our most rapidly producing cells in our body? In our bone marrow, our red blood cells, so you get anemia. Our white blood cells, so you get a decreased immune effect. Our enterocytes, so you get digestive issues. Our nerve cells, so you get neuropathies. These are just rapidly producing cells. So unless you protect those, and again, the analogy I use to my patients is chemotherapy would be like you have a fire, the cancer. The oncologist gives you this great big fire hose, which is the chemo, and you rush into the burning building. The standard of care, the integrative oncology, all the supportive cancer care is really like wearing the mask so that you can handle the fire and put it out. Otherwise, you can't. These treatments, what you will learn, part of this journey that all of you are on and share, is critical. There isn't enough of us to possibly promote this to the level that it needs to be. It's absolutely critical. And again, I mentioned the KRAS and the BRAF cancers, the ones that are most aggressive, and in the youngest of our patients, they respond the most aggressively and the most favorably to more integrative therapies. Reduces fatigue, pain, organ damage, improves quality of life. And with our medical students, and it was actually after that phone call that I reached out to the dean of the medical school and I said, look, I'm going to take 2 of the medical students that are going to be doing rotations at our clinic, and one of them actually just started his residency here at Johns Hopkins. So that's exciting. And we reviewed we reviewed every single piece of literature related to IV vitamin C, ascorbate, et cetera, and chemotherapy, and they were all positive. So we know that high-dose vitamin C combines with chemotherapy, significantly reducing cytotoxicity compared to chemotherapy alone, and improves efficacy across the board. And interestingly, when we did that literature review, there's still lots and lots of studies being published that have oral vitamin C dosing. And what is the minimum therapeutic threshold required? 300. And what's the maximum that you will ever get to with oral dosing? 220. There is widespread recognition that very substantial benefits in cancer management would be achieved if practical methods could be devised to enhance resistance. That's what this is. That's what this exercise is for. The supportive cancer care, the integrative oncology is all of those other things. And that is the future, not just of primary care, but of oncology. And if you want to read more, my book's available. I am available. Feel free to reach out through online means. And yes, and through Instagram, when I go to Greece for the olive harvest, you can follow along and see what living like in abject poverty as a olive farmer looks like. But thanks for your time today, and thank you very much.
Okay, thank you, Dr. Rallis. Thank you so much. We've got I'm sure there's a lot of questions, but we've got a tight 5-minute window. So if you want to race to a mic, you can. I'm going to start us off with a quick question. We've got a tight 5-minute time frame. A reminder to everyone, be brief and be broad in your questions. So my question to you is, for those of us in the room that don't have a cancering process currently, it seems to me that maybe we should use IV vitamin C therapy for all of us as a preventative measure. Is that true, and is that potentially true with mistletoe as well?
Yes and no. I mean, I don't think you necessarily want to be doing an oxidative dose for the sake of prevention. I think that part of our defense mechanisms are to do an antioxidant dose unless you're doing a workup and you begin to find those latent viruses that are there. And I think in those cases, you should be doing a parasite cleanse with IV vitamin C, et cetera, or some kind of a treatment plan that would address those things. But otherwise, you would be focusing on maximizing those levels with antioxidants like glutathione, which we wouldn't normally give in a cancer patient.
Hi. Kind of a three-part. One is, could you address vitamin B6, because Dr. Nasha Winters just cut that out of her supplement. Liposomal vitamin C, I've heard there's for people that can't afford, that like might be a better option than just your ascorbic acid, like chewables or whatever, or other pills, but the fat-soluble ones. And the other one, who can maybe not be a candidate for vitamin C IV, like maybe address the MTHFR gene or something like that?
Yeah, really the only candidate, the non-candidates for IV vitamin C would be patients that have G6PD deficiencies, like glucose 6-phosphate dehydrogenase deficiencies, or if they have significant anemia. Because even kidney disease, which is a relative contraindication, like we've done lots of IV vitamin C at high doses, like titrating up high doses on patients with kidney disease, renal cell carcinomas, et cetera. The second question regarding the liposomal, I don't think that will have a therapeutic effect on cancer in terms.
Better than the other over-the-counter vitamin C? Do you think it's a better choice?
No, I would probably say focus on foods to raise endogenous antioxidant levels, not supplements, because IV vitamin C is a completely different therapeutic. Liposomal vitamin C is a better supplement for sure than standard vitamin C. And the first question.
Sorry, yeah, I got my wires crossed. I was thinking about B6 and probably the Myers cocktail, and we've been told to avoid that by Dr. Nasha Winters now. She's cut it out of her repertoire too.
Yeah, B6 has a little bit of controversy surrounding it. On the flip side too, B6 has value, especially in excess stress and sort of the mitigation of stress spirals. So I use B6 a little bit more carefully anyhow. And we don't use a lot of B vitamins for cancer treatments to your latter point anyhow. Because the same idea that you want just enough B12 or folate to drive red blood cell production, but not enough to drive tumor or support tumor growth. Yep.
Hi. I am curious about the glucose piece. So if somebody's testing with their glucose, how long they should wait after IVC treatment, and why might a CGM go faulty while undergoing IVC?
Yeah, glucose is six carbon molecules. So is ascorbate, and most glucometers can't differentiate the difference. So you can use that to gauge therapeutic levels or therapeutic indices. But you're right, your CGM is going to go sideways. So if you are using that for insulin, you need to be very, very careful, obviously, and that needs to be monitored very closely. But you're right. So yeah, we can use a glucometer to actually as a surrogate measure of ascorbate because they can't differentiate the two carbon chains. But don't base your insulin dosing on it.
Thank you.
Yep. Thank you.